Thank you, Mr. Chair. And first of all, thank you all for being here, and thank you, Mr. Chair, for putting this together and to all of our hosts. I really appreciated the discussion on child welfare issues, and I will tell you, I understand there's a unique and sometimes challenging relationship between the tribes and government entities, and so I appreciate that you recognize that too, and that's we could have a whole hearing on that, so I won't go into it, but I did have to sit down with Mr. Cole from Oklahoma and get a better understanding. So I understood that better as we go through this legislation, so that we're able to address the issues properly and not always we're from the government and we're here to help. So I try not to say that ever, but unless I'm joking. But I talked to a couple of folks. I represent a very rural district, and one of the things is that workforce is obviously a challenge, and I will just say that healthcare workforce in particular is an issue. And Dr. Kupferman, you mentioned in your testimony that you guys added 229 positions. Residency positions. And so I'm wondering if you could maybe talk a little bit about how can the GME program be improved to benefit the rural healthcare workforce, and why is it so important not only to those rural areas, but to the healthcare system in general, and how it really does improve them?
Thank you very much for that question. Certainly, challenges in rural healthcare are not germane specifically to physicians, but all healthcare providers, nurses, medical assistants, people who help run our hospitals, but more in particular, areas around being able to provide coverage in an emergency room, obstetrics and gynecological services in our rural hospitals, EMS services in our hospitals continues to bedevil us in areas where we have our own rural hospitals. And so expanding not just the number of trainees that we are bringing into these locations, but also continuing to invest in some of those incentives that will allow individuals to make that decision that they would like to live in those rural locations once they finish their training. And that's the pipeline that we are building and we continue to invest in. We've just started a rural residency program in northern Arizona. We continue to plan on expanding on that, because once a resident begins their training in a particular location, there's a very high likelihood that they're going to stay there. But we've got to get them into those locations. And so it's being able to expand not just new programs, but even currently existing programs. As I mentioned in my testimony, there's a cap on currently existing programs. And so if there's opportunities to expand on those in areas where we know that there's been extensive population growth, or there's perhaps been closure of other hospitals, and so increasing the radius from which someone in the community would need to travel, that's where we have great opportunities. It's incentives to those hospitals. It's incentives and opportunities for residents to go to those locations, and then also incentives to compel them and encourage them to live in those communities and be part of the fabric of those areas. And it works, but it takes time, and we are fully invested in that process.
And I appreciate that, Doctor. And I recognize that it's not just the doctors, but there's a whole lot of pieces that have to fit together, and that's one of them. But if you bring the doctors, will you get the nurses? If you have the nurses, will you get the doctors? So we have to look at all of the aspects of it. And so I appreciate that you're focusing on rural hospitals, because it's part of having those strong communities in rural areas, and it is a huge portion. Having that health care available is a huge portion of it. So I appreciate that. And I just have a couple of seconds left, and I will just again say thank you to all of you, because this has just been incredibly informative and a great trip and a great hearing. So thank you very much.